chronic disease in the elderly, and she's going to do an update of the literature. And she is the Regional Medical Liaison, the Cardiovascular Division of Sanofi Aventis Pharmaceutical Company. So let's please welcome Lisa Farnett.
Thank you.
Lisa, I'm going to dim the lights a little so
Yeah,
there's a better
so we can
contrast.
see a little bit better. I'll tell you just a little bit of my history. I probably about, what was it, 15 years ago, I think, I used to work on this unit. So I have a little bit of experience in geriatrics. And when Dr. Hartroth asked me to do this lecture, I was really excited about it. When I first started working on this lecture, the title was Use of Anticoagulants in the Elderly, and I started working on that from that perspective. And then I went back and looked at the original email, and he had asked me to kind of touch on it from a disease state topic. And so, fortunately, there are a couple of really nice studies that are just being completed or have just been published on elderly populations. And so we're going to talk about those today and what implications they have for the elderly based on going by disease state. So before I start, I do want to let you know that I am employed by Sanofi Aventis. We do have Lovenox as one of our products, and Plavix is another one of our products. And we will be talking about some off-label information. So if you have any questions, please feel free to ask them during the talk. If you want to get more into some of the pharmacology, we can certainly do that. But there's some data that I wanted to present to you today that it's actually not even been published yet. So I think it'd be really exciting data for you guys to have firsthand. As you know, there's not a whole lot of data out there for treatment in the elderly. The FDA did publish a guideline in 1989 that their purpose was that the population studied should be the population treated. Came out with this guideline. It's not really well followed. I think 1989 was a very optimistic year. Does anybody know what the most popular song was in 1989? Anyone hazard a guess? It's a good one. But no. Don't worry, be happy. So it was pretty optimistic then. So far, I think we've done a pretty good job. You know, people have done a pretty good job trying to get elderly patients into studies, but it's not really where it needs to be. Patients over the age of 75 was only 9% of the coronary disease clinical trial population over the last 10 years, which obviously they make up a much larger percent of the population. And then when you see the elderly patients in the studies, they tend to be healthier than your average population as well. So, having that in mind, we're going to approach this from a disease state standpoint. And these are pretty much the thrombotic diseases that really encompass anticoagulation therapy. So we have deep vein thrombosis, DVT, and PE, and we can approach those from a treatment and prophylaxis standpoint. Atrial fibrillation, non-ST elevation MI, and ST elevation MI. Now, in terms of a data standpoint, there's really not a whole lot new in terms of DVT treatment or non-ST elevation MI, although there was a really nice statement put out by the ACC-AHA about geriatric patients with ACS. Aside from that, there's really not a whole lot of new data. But there's plenty of data for prophylaxis, a little bit for A-fib, and some new data on ST elevation MI that you guys should be aware of. Talk about medical prophylaxis. There are two main studies that have, one has been published in the last year, one has not been published yet. The first one is extended prophylaxis of DVT in medically ill patients. That study is called EXCLAIM, and that was presented in Geneva this past spring, or I guess summer, I guess it was July. But that has not been published yet, but I'll give you the data today. And then DVT prophylaxis of post-stroke patients, which is the PREVAIL study that was just recently published. So when we look at EXCLAIM, the thought behind this study was that we know that medical prophylaxis works in medically ill inpatients. So we know that if you have someone who's immobilized in the hospital, medically ill, we need to give them some form of prophylaxis, which I'm sure you guys do on a regular basis. The problem is that when you send these patients home, they go from the hospital bed to their home bed. You know, are they going to be any better off at home than they were in the hospital? And this study sought to explore that. So they thought, well, if you have extended duration of therapy in hip replacement patients, we know that's beneficial. We know that patients undergoing elective cancer surgery, they do better if you extend the therapy out a little bit longer. what about looking at these acutely ill medical patients that are still going to be immobilized when they go home? Would they benefit as well? So this was the study design. So patients were given, this was sponsored by Sanofi Aventis, so they were given enoxaparin 40 milligrams once a day for the first 10 days of therapy. And this is most of the time that they were inpatient. The average inpatient stay was about 7 days for these patients. So they were covered while they were inpatients. And then they were randomized. This was all open label this period of time. Then they were randomized to either continue getting enoxaparin at home at the same dose or to a placebo injection. And this went on for an additional 28 days, and this is called the double-blind treatment period. And then they were evaluated at the end of that period, and then they had up to 180 days follow-up on these patients. So one of the important things to note about this study is how they define mobility, because this is what you really need to know to apply this to your own patient population. So in the beginning of the study, the mobility was assessed at level 1, and these are patients who are totally at bed rest. Level 2 was basically patients who are bed rest, but they could get up and go to the bathroom, or they had to be walked with assistance. Well, there was an adjustment to that definition. After about 3,000 patients were in the study, they found that the patients weren't having enough DVTs. And this happens a lot with studies. They overestimate the endpoint. And so they thought they needed a more strict endpoint to have a much higher risk group. So they revised the inclusion criteria. So the final inclusion criteria was level 1 mobility, basically these sedentary patients, again, who are over 40, they have to have an acute medical illness or an exacerbation of a chronic illness that puts them into the hospital. Level 2, they still allowed into the study, but they had to meet one of these following criteria. They had to have an advanced age or a lower age with a history of VTE, or an age over 40 with a diagnosis of cancer. Cancer, again, being a very prominent feature in DVT risk. So you can see here across the board, the ages in this population were about 70 years old. So we're getting into a little bit of an elderly population. What's nice about this is the age over 75, 43% of the patients were over the age of 75 in this study. Almost 50-50 male-female, which is kind of interesting. You never really see that in most of these studies. And most of the treatment was started in the hospital. The duration of treatment was somewhere around 26 to 27 days for most of the patients. Now these are the major diagnoses that the patients presented with. Acute infection, respiratory insufficiency, which could be like a COPD flare-up, heart failure, or acute ischemic stroke. And these are the 4 diagnoses that made up over 85% of the cases. And then you have this smattering of other things. Cancer patients made up a very, very small percentage of the study. So if you look at the level of mobility, most of these people were level 1 mobility, so you had patients on total bed rest. So you did have about 35% of the patients who did fall into that level 2 category. And so these are the results, and these will be published soon. Come on over here. Yeah, there's plenty of chairs over here. But it's not been published yet. It'll probably be published in the next couple of months. So you guys are some of the first people to lay eyes on this outside of Geneva. So these are the results of this study. So we have in the placebo group here in red and the enoxaparin group here in blue the rate of thrombosis. And so you can see here that in the placebo group was 5% and the extended prophylaxis group 2.8%. Relative risk reduction of about 44%, and it was statistically significant. So this is a prolonged prophylaxis. After the 10 days of hospital prophylaxis, they got an additional 28 days of prophylaxis. So now looking at these DVTs, kind of separating them out, kind of really looking at how these were measured. Now these are measured by duplex ultrasound. So this is not a venography study, so the way that you can pick these up are either the patients are symptomatic or you can pick up asymptomatic proximal DVTs, but the DVTs they're going to pick up on the ultrasound are going to be your larger DVTs. You're not going to get the small, insignificant DVTs that you see in other studies. And so here you see that there was a very large difference in the difference in the proximal DVT rate. Which again, these are the most dangerous DVTs that can go to PE, and a significant difference in the symptomatic VTE rate as well. So if you look at PE rates, they're kind of hard to compare because there were no PEs in the enoxaparin group and very few PEs. These bars look huge, but look at these numbers here. You know, they're 0.2% over here, 0.1% over here. Part of the reason that you don't see these is because over here, when we had these DVTs, all these DVTs were treated. So a lot of them never had the chance to get to PE, so we don't really see a big PE rate in the study. In terms of safety endpoints, enoxaparin did have a little bit more bleeding than placebo. 5.7% here, 3.8% here. This is total bleeding. Major bleeding rates were extremely, extremely low across the whole study. You'd see the difference really in minor bleeding rates. And minor bleeding can include like ecchymoses at the side, hematomas, those kinds of things, which we see quite a bit with anticoagulants. So if you look at the major bleeding issues, where was the bleeding occurring in this study? There was one fatal bleed in the enoxaparin group, and that was a hemorrhagic conversion of ischemic stroke. There was one intracranial bleed, one interocular bleed, and 9 other. And you can see the definitions down here that are just kind of all over the board. Pretty much what you'd see with any anticoagulant. You can have some miscellaneous bleeding, but there were 12 major bleeds out of this 2,000 population and 3 in the placebo group. So overall, if you wanted to figure the net clinical benefit from this study, the number needed to treat to avoid one venous thrombotic event is 46. So you need to treat 46 people with enoxaparin for 28 days or low molecular weight heparin for 28 days to avoid one thrombotic event. The number needed to harm, even though the bleeding rate is a little bit higher on anticoagulant, you'd have to treat 224 to cause one major bleed. Any questions about that study or thoughts? Issues you guys have? Study you all. So the next study is DVT prophylaxis in stroke patients. And this is a study that's actually, the PI was around the corner from here. David Sherman over at the University Hospital was the PI for this study. So we're looking at this PREVAIL study, prevention of VTE after acute ischemic stroke with low molecular weight heparin and enoxaparin versus unfractionated heparin, and the impact of stroke severity. We'll talk about what that means. Basically, this study has not really been done in a very good form where you would give prophylaxis to a patient who's had an ischemic stroke but is paralyzed from the legs down. And people are a little afraid to give anticoagulants after stroke because of hemorrhagic transformation, but then they have a high DVT rate, and so this is a nice study to really show what happens, and is your high-risk patient any different than your lower-risk patient. So we're looking at the efficacy and safety of enoxaparin according to stroke severity as measured by the NIH stroke scale. So the way the study was designed is that this was actually an open label study, and they had patients who are confirmed to have an acute ischemic stroke either by CT or MRI, and they were started on anticoagulant therapy within 48 hours. As long as there was no hemorrhagic transformation, they were started on the drug therapy within 48 hours. And they were randomized 1-to-1, either enoxaparin 40 milligrams or unfractionated heparin 5,000 Q12. And they were given this therapy, standard medical prophylaxis therapy, for about 10 days. There's some seats up here if you want to pull some chairs. So, unfractionated heparin Q12 is not something that we normally do for DVT prophylaxis. Do you guys use unfractionated heparin for DVT prophylaxis in the hospital?
No, but not at TID.
Yeah. TID is the standard regimen that has been shown to be effective. And so one of the criticisms of this study is, well, why did you pick Q12? Why would you pick an ineffective regimen? And the reason for that is that it's not ineffective, it's not as effective as TID. But the problem was that this was a study done by Hillbaum, back in 2002, looking at this very same population, this ischemic stroke population. And what they found was that in using the heparin TID, there was a very large hemorrhagic infarction rate. And the people who were designing the study, including Dr. Sherman, were a little concerned that if you used unfractionated heparin TID, that you could skew the study, or obviously endanger the patients, but you're also going to skew the data in that direction as well, and you get a lot of hemorrhagic infarction. So they didn't feel it was safe to use unfractionated heparin TID in this population. So they went to the BID regimen. So the inclusion criteria, obviously you had to have a stroke within 48 hours. But the key issue is you had to be impaired. You could not be able to walk in this study due to impairment of the leg. Exclusion criteria, of course, there's a million different exclusion criteria. Nothing significant that would really jump out at you. Obviously, if you have a history of intracranial hemorrhage, if you're at risk of that, you wouldn't want to put the patients in the study. If you had a malignancy that may pose a risk of bleeding, cerebral aneurysms. They did not allow anybody in the study who was comatose either. Had to be fully alert. They also could not have any prophylaxis for more than 48 hours before the inclusion in the study. So the primary efficacy endpoint was a confirmation of a DVT during the study, either symptomatic or asymptomatic, symptomatic PE or fatal PE. Now, everybody in this study got venography. And this was a very difficult study to do because they were trying to get people enrolled in this study. People didn't want to be enrolled in this study because of the venography. But they were able to get it done. They did get the number of patients they needed, but realized that we're going to have a lot more clots in this study because they used venography. Now, for PE, they only looked at symptomatic PEs. They did not go screening for PEs in anybody who had a DVT, only if they were symptomatic for the PE. And then the primary safety endpoint was at 48 hours, looking for the intracranial hemorrhage, any extracranial hemorrhage, and looking at mortality issues. So, the primary safety endpoint, they had to be verified by a CT scan or an MRI, and there could be a lot of different classifications for this primary safety endpoint. You could have an asymptomatic hemorrhagic transformation, a symptomatic hemorrhagic transformation, a primary bleed, subarachnoid, subdural, epidural. They classified all the bleeds out as far as that. And then the major extracranial hemorrhage was anything that resulted in death, major decrease in hemoglobin greater than 3, transfusions greater than 2 is fairly standard definition if you had to have surgical intervention or decompression, or a retroperitoneal or peritoneal or intraocular bleed. And then the safety endpoint with clinically important bleeding was via symptomatic intracranial hemorrhage or symptomatic extracranial hemorrhage. So they had 1,762 patients. It wasn't a huge study, but it was a good number of patients. The duration from the time they had the stroke to the initiation of prophylaxis was around 1.2 days. So the drug therapy was started fairly early in the process. Mean duration of therapy was about 10.5 days, at which time they had the venography. So looking at the demographics in this study and the patients who were involved, trying to apply them to your population, the age was 65 or so, 66. A little bit more on the male side. BMIs were about 27. Thrombolytic therapy was only used in about 6 to 7% of patients. And then most of the patients had an UTHSCSA score of less than 14, 73%, 71% in this group. The average score was 11. So when you look at the patients coming into the study, the baseline therapy, how many patients were on antiplatelet therapy? 92% of patients were on antiplatelet therapy walking in the door. Most of which was aspirin, some of which was aspirin diprotamol combination, a little bit of clopidogrel. There's a little bit of overlap there.
Is anybody on aspirin combo?
They didn't report that. And we've asked Dr. Sherman for that information. They're probably going to, we looked at the data in the secondary analysis, but that was not in the primary analysis. So in their primary efficacy endpoint, looking at the intention to treat population, enoxaparin 40 milligrams once a day was more effective than the unfractionated heparin twice a day. So in terms of symptomatic, asymptomatic DVT, symptomatic or fatal PE, and this is at day 14, so you see 18% versus 10% statistically significant p-value, 43% relative risk reduction, 8% absolute risk reduction. So if you look at proximal versus distal DVTs, again, we have the distal DVTs because this was all done by venography. Proximal DVTs was about 5% here, but 10% in the unfractionated heparin group. Distal, even less distal, 7%, 13% here. And then if you look across the board in patients who had both, again, everything seems to be statistically significantly lower in the enoxaparin group. So, if you look by stroke severity and look at the VTE rate, the patients who had a higher severity score, greater than 14, had a higher stroke risk. Had a higher VTE risk overall. But enoxaparin was still statistically significantly better than unfractionated heparin in both groups. Even you could almost say even almost a little bit better here. The relative risk reduction was 45% versus 41%, but it's basically about the same. The difference in the two treatment groups was maintained whether the severity score was low or high. So the incidence of bleeding at the end of treatment and then going out 48 hours. Total bleeding actually was not different between the two groups. Intracranial hemorrhage rate was not different between the two groups. Death of a patient with a symptomatic intracranial hemorrhage was not different between the two groups. And then major extracranial hemorrhage, again, a little bit higher in the enoxaparin group, and it is statistically significant. This is the key point here, is that we didn't see the symptomatic intracranial hemorrhage rate that we've seen in other studies. So the incidence of bleeding, again, at the end of 48 hours, the other bleeding parameters, clinically important hemorrhage, really no difference between the two groups. And patients who died of the hemorrhage, no difference. And then minor bleeding, no difference between the two groups. So, again, this is more bleeding. We're obviously very interested in bleeding in this study. Again, no differences between the two groups in terms of death, hemoglobin drop, or transfusion, and the individual bleeding parameters. Mortality difference, there really wasn't a difference in mortality between the two groups. Really saw a difference in VTE rate, but no resultant decrease in mortality. So in summarizing this study up and looking at the numbers needed to treat, the number needed to treat to avoid 1 VTE is 13 in these patients. Number needed to harm or to cause a bleed is 173. Again, net clinical benefit in favor of the enoxaparin. Any questions or thoughts on this?
So what was the mean age? I missed that on the Korea study.
What's that?
The mean age?
The mean age was about 65. So it's a little bit lower, but I think that's really consistent with the mean age of the stroke population across the board. It's about 10 days, plus or minus 4. So it was, yeah, on average in the study was 10 and a half days. So, just a couple things to mention about atrial fibrillation. I know everyone loves to use warfarin in older patients. It's just the thing to do, right? I used to be in the anticoag clinic here too. Interestingly, though, I actually don't have to slide it here. If you actually look at, in well-controlled studies and well-controlled patients, as I'm sure yours are, the bleeding rate with warfarin is not that different than the bleeding rate with aspirin. And you'll see some of that in this study as well. This is a study called ACTIVE. Is anybody familiar with this study? Did you guys talk about this before? Okay.
Oh,
Not in GG.
Not in GG. Okay. This is a study that part of which is still going on. The study was designed to look at atrial fibrillation and trying to get an alternative to warfarin. So looking at clopidogrel plus aspirin, which is what you asked about earlier, looking at clopidogrel plus aspirin, whether that's going to be as good as putting someone on an oral anticoagulant. In general, this is more of the study design. So you have a patient with atrial fibrillation, and there were two arms to the study. One is if they were warfarin candidates. So if they were someone who could tolerate warfarin, who you felt comfortable putting on warfarin, those were patients who could be randomized to this arm of the study. And that study was called Active W, and it was warfarin versus the combination of clopidogrel and aspirin. If they were not eligible for warfarin, for some reason they couldn't take warfarin, people didn't feel comfortable putting them on warfarin, if they were a fall risk, whatever the clinician really decided, they could be in this Active A arm. And those are patients who are on aspirin or clopidogrel plus aspirin. Does that make sense? Those are the people that you'd probably put on aspirin anyway for their AFib. There was a secondary factorial design where patients were put on irbesartan. We're not going to talk about this today because this data is still being processed. And irbesartan is thought to cause a little bit of remodeling in the heart, and thought to maybe put people back into sinus rhythm or control the atrial fibrillation a little bit. And so the thought was, you know, if you added irbesartan to whatever treatment here was effective, that maybe you'd get even a more beneficial effect from your therapy. But that's a secondary result that we don't have any data on. So the patients who are in this study, we're going to talk about, the arm of this study has been closed out, and that's what we're going to talk about today, is clopidogrel plus aspirin versus warfarin. This study is still going on. We'll talk about why that is. So the Active W patient characteristics are about 3,000, a little over 3,000 patients in each group. Clopidogrel plus aspirin versus oral anticoagulant. This is international, so it could be warfarin, acetylfumarole, those kinds of things. Average age was about 70 years old. CHADS 2 score was about 2 for all of these patients, which puts them at a stroke risk of roughly about 5%. You guys familiar with the CHADS 2? Do you guys use that?
We heard.
Yeah. People are it's been out for a while, but people are really starting to warm up to it now and really starting to use it. I'm seeing it in a lot of publications as standard now. Baseline oral anticoagulation, about 76% here, 78% of patients came in on oral anticoagulation. 30%, 26% on aspirin, and a few patients were on Plavix, probably for other reasons. So, results of the study. So we have here in the yellow line the clopidogrel or Plavix plus aspirin group and the oral anticoagulant group. And you can see these lines diverge pretty quickly from the very beginning. And we're looking at the cumulative hazard ratio, which is the systemic embolism, MI, and vascular death as the result. So this arm of the study was stopped because there was clearly a difference between these. That warfarin was clearly, or oral anticoagulation was clearly more effective than using antiplatelet therapy. The thought was, when this study was started, was, you know, if you can use antiplatelet therapy for stents, you know, use dual antiplatelets, that maybe by combining them you can get the same effect as warfarin, and we can get rid of that horrible, horrible drug. And it didn't. So this is clearly not as good as oral anticoagulation. So if you have a patient who's a candidate for oral anticoagulation, it's definitely the much better therapy. You see the stroke rate here is about 5.64% per year. That's pretty much what you'd expect with a CHADS 2 score anyway. And here you're down at 3.93%. Interestingly, the bleeding rates were not that different between the two. And I just think this is kind of an interesting reassurance that if you can use the oral anticoagulants, you know, in a very structured way, that you can really minimize some of the bleeding. So the Active W arm was discontinued because the efficacy of warfarin was so great in this study. The Active A arm, which is just going to be the clopidogrel plus aspirin versus the aspirin alone arm, will continue. And that study will be closed out probably early next year, and we'll probably have some data late next year on that part of the study. And I think that'll be really interesting because we just don't know what to do with those people. I mean, it's clearly that warfarin works, but if you can't put them on warfarin, what's the second best thing to put them on? And this will really answer that question. And then the irbesartan issue will also be answered in that secondary analysis.
So there's no comparison of warfarin with aspirin alone?
No, those studies have been done.
The old style
Yeah.
studies, the new ones.
There was no reason to do that because I think the old studies have really shown that warfarin was superior to aspirin. Aspirin has about a 22% efficacy rate. It's not completely ineffective in stroke. You can get a decrease in atrial fib, I mean.
Yeah, I'm not talking about, I'm talking about the bleeding rate.
Mm.
I'm not talking about the study that, of course, and there's no doubt that warfarin is superior to aspirin.
Oh, and the bleeding rates?
Yeah, bleeding rates. Like comparing warfarin with aspirin alone.
Yeah, there's a really nice publication from the AFI, the Atrial Fibrillation Investigators, which we can talk afterwards and I can get you that publication. But the bleeding rates, they actually did a meta-analysis and put the bleeding rates all together from the warfarin studies and the aspirin studies. And in the warfarin studies, it was about 1.3%. In the aspirin studies, it was about 1.4%. So they were not that different. Any other questions, thoughts on this?
Then what is, we as clinician, when we think that our patients are fall risk or for some other reason with history of bleeding, active GI bleeding, we usually, prefer aspirin over warfarin given the fact because it's a bleeding risk.
No,
but if there is,
those patients were not that category patient though. These are de novo patients that had never had a bleed. Now, so if you have somebody who's had a bleed, I think you're in a totally different picture, and so then you have to think about protecting the stomach and maybe, using something to prevent another GI bleed, like Prilosec. I don't know what you guys have on point. I don't want to throw out names, but some type of acid-suppressing medication to help with that and those kinds of things. So, and then you have to start weighing whether that's even worth it. Is the bleeding risk higher than the stroke risk for that particular patient? And you start to get into a lot of clinical decisions in patients who have a history of bleed or bad fall risks and those kinds of things. Any other questions? So basically we'll see what the next results are, but in terms of that question, that burning question, is there something better than warfarin for our A-fib patients? Right now the answer is no. Now people are actively working on things. Many companies are trying to come up with something better, but nothing is really close to coming out at this point. ST elevation MI is the last thing I wanted to touch on. We only have a few minutes, and we can leave some time for discussion either on this stuff or get into some pharmacology. But I wanted to make you aware of this. I know you guys don't treat ST elevation MI on a day-to-day basis in the geriatric unit, but there are very strong geriatric implications from this recent study that was just published, which is called Extract TIMI 25. Are you guys familiar with this study? Did you talk about it? Okay. So I want you to, being geriatric practitioners, there's some things that we need to bring out from this study. This is obviously a STEMI study. Patients getting lytics coming into the hospital, and when you use a thrombolytic, you need to use some type of heparin with it, either unfractionated heparin or low molecular weight heparin or something with thrombolytic. So this was a study to look at whether enoxaparin produced greater reductions than a strategy of using unfractionated heparin in these patients that are getting fibrinolytic therapy. The reason this is interesting from a geriatric perspective is that the previous studies that have looked at this have shown that patients over the age of 75 had this huge intracranial hemorrhage rate. And that study was called ASCENT 3+, where the patients were given enoxaparin with a lytic at the same dose as younger patients. And they had a very large intracranial hemorrhage rate. And so people would back off from using any low molecular weight heparins in elderly with MI for that reason. Well, they went back and looked at this and they thought, well, the dose of enoxaparin that was being used in older patients was probably too high. So they went back and redesigned the studies, and patients coming in with an ST elevation MI, they were getting aspirin, and they would either get unfractionated heparin, usual dose, or enoxaparin. And if they were under the age of 75, they get a 30 milligram IV bolus and 1 milligram per kilo sub-Q Q12. If they were over the age of 75, it's what we call the 75-75 rule. And so they would get 0.75 milligrams per kilo with no bolus. Okay, so if they're 75, you get 0.75 milligrams per kilo, then you get a reduced dose. So, and what we found in this study is overall there was a benefit of enoxaparin over unfractionated heparin. So enoxaparin was given for 7 days, unfractionated heparin was given for 2 days, so you have to take into account the strategy that was used as well. There's no data, there's actually data out there that shows that continuing the unfractionated heparin longer than 2 days was not beneficial to patients. It didn't decrease the thrombotic rate, it only increased the bleeding rate. So the decision was made to use the unfractionated heparin for 2 days. All of the low molecular weight heparin studies out there, enoxaparin, fondaparinux, dalteparin, all used a 7-day course of treatment. So they used the standard low molecular weight heparin treatment and the standard unfractionated heparin treatment. But again, you need to take the strategy into account when you look at that there was a big difference in the outcomes in these patients. So the bleeding endpoints overall, in the purple group is the enoxaparin, and the purple group is the unfractionated heparin, and the blue group is the enoxaparin. Overall, there was a very slight increase in the enoxaparin group. So there is a little bit of excess bleeding that was statistically significant at 30 days. In the major bleeding, you didn't see it. This is the intracranial hemorrhage rate. That did not increase overall. So the question is, was this due to the elderly? So the answer, I'm going to actually skip over that for a second. The answer is, in the subset of patients who were older, they did a predetermined sub-analysis of these older patients. And they found if the age was less than 75, the bleeding rates were 1.9% in the enoxaparin group, 1.1% in the unfractionated heparin group. Above the age of 75, the gap actually narrowed, and you didn't really see an excess of bleeding rate in the older patients. So the thought was that from this study, that the rates of intracranial hemorrhage were similar in both groups in the age over 75. And so that the change in dosing was really beneficial in the older patients. Does that make sense? Go back real quick. So this is the dosing, and the other reason I bring this up is because this is actually in the package insert now. This is actually a new indication for the drug. So if you get asked about it, it is a new indication. There is dosing for geriatric patients. So if the patient is less than 75, again, this is the same dosing we talked about. Over the age of 75, they don't get the bolus, 0.75 milligrams per kilo, Q12 hours. The first 2 doses that patients get in this regimen are capped. So if you're over the age of 75, you're capped at 75 milligrams. And that's only because you have the thrombolytic on board. And the point that I think we need to make is that you don't cap the dose if there's no thrombolytic on board. There is no dose cap, per se, for the drug. It's only in that particular situation. And then they look at severe renal impairment as a separate issue. We know that renal function declines with age, but with enoxaparin particularly, and with most low molecular weight heparins except for fondaparinux, you see that the renal impairment issue is different than the age issue. So you don't really see a connection of clearance and age in most of the low molecular weight heparins, except for fondaparinux. There's a very clear directional change in clearance with age. But for all the other low molecular weight heparins, it's really more related to specifically to the renal impairment. So if you look at renal impairment, you adjust the dose for a creatinine clearance of less than 30. In patients who are less than 75, again, this is the same dosing. You get 1 milligram per kilo once a day. Over the age of 75, no bolus. Again, you only dose the drug once a day, sub-Q. So in summary, for what we've talked about today, we have a lot of new data out there that's applicable to elderly patients. There's prolonged prophylaxis in medically ill patients that have continued immobility. Prophylaxis in the ischemic stroke patients that's been shown to be beneficial if you start the drugs within 48 hours. We have some data with atrial fibrillation patients that's coming, and patients who can't take warfarin. If they can take warfarin, it's beneficial to do so. And then modified low molecular weight heparin dosing in STEMI with lytics, we've overcome some of the treatment issues in treating this population. Any questions or thoughts, issues that you guys have, either related to this, or we can talk more about pharmacology issues, or?
I guess one of the transition points is like someone leaving acute medicine and going to a subacute or nursing home type environments, and it's always been especially if they've been a chronically, you know, if they were bedbound before they came in, and then you DVT prophylax them while they're acutely ill in the hospital, and then when they leave, go back to their normal state. I think that's just more confusing.
Yeah, I think the issue is that something caused them to come into the hospital, right? So it's probably an exacerbation of some major thing that's going on. And if it's CHF or COPD, those are the two big ones that really seem to stimulate coagulation, or cancer obviously, of course. But, you know, in those two cases particularly, those are the cases that showed up in the EXCLAIM data. Those are the ones that you might want to consider a prolonged anticoagulation from the EXCLAIM data. And when we say prolonged, it's not 6 months to a year. It's, you know, just going out to 28 days instead of the 10 days they were in the hospital. And those patients showed that they really benefited from that. Now, you wouldn't want to continue it indefinitely in those patients, but as long as your orders were cleared, you know, just for that 28-day period, that would work out. That's why I wanted to show you this data today, because that's the patient that everybody always worries about, or they put them on extended prophylaxis and then they feel bad about it because there's no data. Now we have data.
Days after they are discharged, or while they are having the excessive use?
It's 10 days in the hospital, and then prolonged therapy 28 days.
Total of 28 days, right?
Yes.
There's probably nothing about people who never get out of bed again, who go home and live for years in a bedbound state.
Yeah, there's nothing about that, but the thought is that at some point their DVT risk goes down to a baseline where that, you know, if you continue giving them anticoagulation, you might be at more risk of causing a bleed than actually preventing anything, that their body might somehow stabilize in that state. And so it's hard to know what to do with those people.
We don't do anything with them until they have their clot, and then we treat them standardly, but then they go back and they never get up again. And
yeah, most people don't. If they've had a clot, then you can make an argument for keeping them on anticoagulation longer. You know, on oral anticoagulation longer. You know, you don't necessarily have to use injectable prophylaxis. You know, there's lots of other options, but I think most people would do the same thing. Just keep them in an observation because there's no data to show.
Now, you mentioned like the renal dosing when it came specifically to that one study, but overall the use of low molecular weights with renal dosing in any states, not just for STEMIs or non-STEMIs.
Right.
Just for medically ill. Are they kind of the same?
Yeah, I actually have a slide on that, but I can tell you. I can tell you, with dalteparin and tinzaparin, there are no guidelines on how to adjust the dose. It just says use with caution in renal failure. In enoxaparin, we have clear guidelines that you need to reduce the dose if their creatinine clearance is less than 30. If they have a creatinine clearance above 30, we don't do anything. Below 30, generally if it was 40 milligrams once a day you were giving them, or 30 milligrams twice a day for prophylaxis, it goes down to 30 milligrams once a day. If it's a treatment dose, on enoxaparin, it was 1 milligram per kilo BID, it goes down to 1 milligram per kilo once a day. Now for fondaparinux, do you guys use any fondaparinux? Very rarely. They don't have any dosing guidelines for renal failure, but there's a clear relationship between the renal function and the clearance of the drug. It's completely contraindicated in patients who have a creatinine clearance less than 30. The clearance is significantly decreased in that 30 to 50 range, but they don't have any dosing guidelines on how to do that.
And also the morbidly obese patients when you're trying to deal with weight.
Yeah,
weight
there are,
decision issues.
yeah.
Which one do we use?
Not that we have that problem in
I
San
know.
Antonio. There are no caps on dosage for enoxaparin or tinzaparin. Dalteparin is not approved for treatment, but in Canada, where it is approved for treatment, they actually have capped the dosage because they said they did find that there was, once they got to a higher dosage, there were bleeding issues. With enoxaparin and tinzaparin, there is no dose cap. In the elderly patients, or in the, obese patients, I think the biggest fear is actually underdosing them. You really have to be careful about, underdosing them, but there's no reason to cap the dose, and if you look at the data that shows the relationship between dose and weight, there's no plateauing of effect, there's no indication that you would ever have to cap the dose. For treatment. For prophylaxis, it's a standard dose. It's a single dose, but that issue comes up in prophylaxis. That is it going to be enough for some patients, and that's a huge issue in bariatric surgery, which you can imagine are the largest patients. And there are a couple studies showing that you do need higher doses in a bariatric surgery patient. No one really knows what the optimal dose is, but for some of those patients, they do use a little bit higher prophylaxis doses.
Now, what about applying some of that data from the post-MI geriatric patients where they do the 0.75 milligrams per kilogram to the PE, DVT, like we had talked about before, having seen so many more bleeding risk? Is it possible? I mean, I don't know if they have the data. Has anybody looked at the data of PE, DVTs in the geriatric patients with the bleeding risk?
No. No, but one of the reasons that I bring this up is to really stimulate those kinds of thoughts too. I mean, those are things to really start thinking about and looking at from your side of things as well.
So besides the 0.75, also they didn't bolus on that either, did they?
Right. They didn't get the 30 milligram IV.
So I was kind of, it's also another.
Yeah, that's another thought. Yeah, that the
How much of
bolus.
a bolus effect?
Yeah, the bolus is going to peak within 5 or 10 minutes, and it's probably going to stick around for about 2 hours in those people with poor renal function. Obviously, will stick around a little bit longer, but your peak on that is going to be much higher than on your sub-Q dosing, and so you're really going to impair a lot of 10A activity very, very quickly. And so if you eliminate that bolus, potentially you can eliminate some of the bleeding risk from that standpoint.
And we're also thinking that in some of the stroke patients too.
Yeah.
People live with bolus and just gradually.
Right.
bring those. I'm sorry.
Oh, that's fine.